online for the public.
Okay, Chair, we are now live. You can go ahead and call the meeting to order.
Thank you. So we'll call the meeting to order. Should we call for the quorum, or we can proceed with the non-quorum items? We can go ahead, call for the roll call, please. Let's see who all are on.
Absolutely. It looks like we do have a quorum now, Chair.
Okay.
I'll go ahead with the roll call. Chair Khan,
Present.
Commissioner McAllister, she is absent, and let me know. Commissioner Roa Dugan.
Present.
Thank you. Commissioner Grady. Commissioner Slimowitz.
Present.
Thank you. Commissioner Van Houweling.
Present.
Thank you. Commissioner Bond.
I'm here.
Thank you. Commissioner Tyler Garner.
Present.
Thank you. Commissioner Winkler is also absent. Vice Chair Rubelid.
Present.
Thank you. Commissioner Flo Khan. She was going to be late today. And Commissioner Ralston.
Here.
Thank you. Chair, you do have a quorum.
Thank you. So proceeding to the next item for possible action is the approval of May 18th minutes. I presume everybody received the copy of the minutes and has had a chance to look at them. And is there any correction, changes, or modifications by anybody? If not, I would like to entertain a motion to approve the minutes.
This is Commissioner Van Houweling. I'd like to make a motion to approve the minutes, Chair Khan.
Thank you. Second? Is there a second?
I move.
Thank you. So anybody opposed? Seeing or hearing none, so that's approved. The minutes are approved. Public comment. So we'll open up to public comment, and just a reminder that public comments, we'd like to limit them to 3 minutes to give opportunity to everybody to be able to give their viewpoint. Anybody for public comment in person or in writing up north or south, Melinda?
Yes, it looks like I do have public comment from Ms. Helen Foley, and I should have empowered you to be able to speak. Please go ahead.
Thank you very much, Dr. Southard, Chair Khan, and PPC commissioners. The Nevada Association of Health Plans is a statewide trade organization representing 9 member companies providing commercial health insurance and government programs to Nevadans. Our mission is to ensure that the growth and development of a high quality and affordable healthcare delivery system is endured throughout the state of Nevada. The NAHP has and continues to engage in all of the PPC meetings by way of reviewing and listening to them, and is committed to being a resource for the commission. In an effort to be helpful, we believe that some of the concerns that we have should be expressed to you today. One of them is the lack of insurance industry representation. The NVAHP believes that any discussion on healthcare issues would benefit from having all segments of the healthcare industry represented. Unfortunately, as the PPC discussions ensue, it has become apparent that the commission does not include members who understand the health insurance market. Therefore, the lack of understanding has affected some of the recommendations and decisions that you're about to make as the PPC. The NVAHP believes that someone with an understanding of the industry that the state regulates could have provided information that would have assisted in several of the discussions that you've had. we respectfully recommend the PPC consider a bill draft to add an individual who represents the insurance industry. Here's some of the examples that we have where we feel that we could have been helpful to you. One deals with fiscal impact and the premium tax implications. At the May 18th meeting of the PPC, several BDRs were discussed. And NVHP shares a concern that during those discussions, the potential impact of several of the BDR topics could have on the state were not even raised. An insurance industry expert could have shared with you what they have experienced in other markets and allowed the PPC to consider the fiscal impacts on the state. Another one that we are extremely proud of that should have been brought forward is the affordable housing initiatives. With this discussion, we would like to let you know that other services could have been aligned with the several BDR topics discussed on affordable housing initiatives. As part of our Medicaid managed care contracts, for example, as part of Nevada's 2022 managed care contract, the state actually requires MCOs to invest 3% of pre-tax profits into the community being served. Many of these investments, including housing programs and other initiatives. Outside of this contract, our MCOs have included affordable housing options as value-based programs. Further, the Healthy Living Expansion, HLE, is a cooperative public-private partnership, including Clark County Department of Social Services, Anthem, Health Plan of Nevada, Silver Summit, Molina, Help of Southern Nevada, and the Southern Nevada Homeless Continuum of Care. And it has proven to be extremely successful in the South. The HLE is a permanent supportive housing project serving the most housing-focused case management, medical care management, and supportive services to assist households in becoming self-sufficient. We would love to get into more detail and help you with that. One of the other issues that concerns us is the Orisa Preemption. Now, we hear about Orisa. It is the Employee Retirement Income Security Act of 1974, and it actually sets up the self-insured health plans. And it's a critical issue, and the PPC should consider as it attempts to gather information regarding healthcare costs and spending by organizations providing healthcare coverage. While the state of Nevada, through the Division of Insurance, has the authority to regulate and request information from the insurance companies it regulates, the division and the state have no authority over many of the organizations that provide healthcare coverage in Nevada, including Orisa self-employer.
Sorry to interrupt you. What's the time frame, Melinda?
Yes, we're running at 4 minutes, Dr. Khan.
Yeah, so Ms. Foley, sorry to interrupt, but I think we could put in your recommendation in writing as a part of our official record for sure. And
that would be fine, Dr. Khan. I would like to wrap it up in about 15 seconds, if you don't mind.
All right.
Only 17% of the fully insured product in Nevada, all of those people that receive insurance in Nevada, whether it's from the state or from the federal government or different sources, only 17% is determined by the Division of Insurance. So you're just looking at a very small amount. I encourage you to take a look and see what we have provided here. We look forward, we're going to have a meeting with Dr. Southard, and we really look forward to becoming a real partner to you as you go through these steps. We also want to make sure that we have backup information from the Baylett Health on where some of the statistics come from. I thank you so much. It's a lot that we've put forward, but we felt that it was important and we wanted to share it with the committee today.
Thank you very much, Ms. Foley. Really appreciate that input. Just a quick closing comment on this subject, not for discussion. The structure of the commission is strictly the governor and legislature. So who serves on this commission is not the prerogative of the commission. Reference the question of BDRs. All the commissioners have had the opportunity to recommend their own viewpoints on various potential BDRs, and we'll be deliberating on some of those today and beyond, and they'll be narrowed down and prioritized. Anybody is welcome to give their input in public comments or in writing ahead of the meeting and will be provided to all the commissioners to make sure everybody is heard and their input is taken. So having said that, we'll move on to anybody else.
Yes, thank you. I do see Mr. Patrick Kelly has asked to provide public comment.
Good morning. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association. I've shared with many of you the fact that we have a severe nursing shortage in Nevada. Today, I want to share with you that we have a large physician shortage as well. Nevada needs more than 1,500 physicians just to reach the national average. Not to be at the top, but just to be average. We are near the bottom nationally for the number of physicians per 100,000 population. We have this shortage at a time when our population continues to grow and programs like the public option will expand coverage options. We urge you to proceed cautiously with any initiative that might impact physician recruitment and retention. Nevada cannot afford to decrease access to healthcare. Over the last 20 years, the manner in which physicians practice medicine has changed. Years ago, physicians frequently hung their shingle out and practiced independently or in small groups. Increased regulatory requirements, billing and collection challenges, and poor reimbursement changed that. Physicians young and old want to be employed. They don't want the hassle of running a practice and complying with the latest regulatory changes. They just want to practice medicine, they want to be paid a salary, and they want a balanced work and family life. Young doctors leave medical school with large student loans. They often want and need a guaranteed salary to pay off their loans. They don't want to go to a bank and borrow money to rent office space, pay medical malpractice premiums, buy medical supplies, purchase furniture, computers, medical equipment, and pay staff while waiting months to receive reimbursement for the services they provide. Individually or in small groups, they have no power to negotiate rates with payers and are typically given a take it or leave it offer. Quite simply, the private practice of medicine is not attractive, particularly in Nevada, where Medicaid rates are low. As you make policy decisions, please consider the unintended consequences of your actions. Physicians can go anywhere in the country to practice. It's already difficult to attract and retain them to the state. Please don't make it more difficult. Quality healthcare and good patient access depend on having enough healthcare providers to serve our state. Thank you.
Thank you very much. Appreciate that input. Anybody else, Melinda, in the public comment?
Let's see. If anyone else would like to provide public comment, please press *9. Okay, I am not seeing any additional public comment, Chair.
Okay, thank you. So we'll move on to our next item, number 4, for possible action. I'm not sure whether we'll be able to get to a possible action today, but it's for discussion, review, and discussion of possible bill draft request topics. So in the interest of time, Melinda has allocated 110 minutes. So there is a fairly large number of suggestions by various commissioners on bill draft requests that they would like to be considered. We went over some last time. There are others to be looked at. So I would hand it over to Melinda in the interest of time to kindly be precise and to the point of the reasons why one would want to have that particular BDR topic considered. And after the presentations are made and questions answered, then we will take it up at our next meeting to narrow things down, to prioritize them to the limited number of BDRs allowed, a couple of them actually, in the subsequent meetings. So let's proceed with that. Melinda, you want to take it from here?
Thank you, Chair. Yes, so I just wanted to quickly give an overview to orient everyone on our recent and upcoming PPC activities. So as you can see, planned for today, we have a discussion on the remaining BDR topics, a review on health insurer and hospital quality performance data, review of quality benchmarks in other states, and to consider some quality strategies for Nevada. Next slide, please. And now moving into discussing the remaining bill draft requests. So to assist in our discussion today, I again provided the document outlining each of the 16 potential BDR topics that were submitted by the commissioners that are organized into general topic areas. Please note the number next to each BDR topic on that document will not match the number presented on today's PowerPoint. I apologize for that. Additionally of note, as was requested during our last meeting, we had given the opportunity for our newest PPC commissioner to submit BDR topic ideas for the commission to consider. However, due to time constraints, the commissioner opted not to submit any new topics for consideration by the PPC for the 2023 legislative session. To be compliant with open meeting law and our due diligence to the public, this agenda item today will only surround sharing information on each proposed BDR topic and allowing opportunity for discussion among the commissioners. Prior to today's meeting, all commissioners presenting BDR topics for consideration today were asked to prepare for each topic a summary, a justification of alignment with the charge of the PPC and the importance of the topic, as well as any suggested detailed revenue sources for any topic with state budgetary implications. Our discussion today is only meant to give a strong basis for our continuing BDR discussion. I want to allow all commissioners time to thoughtfully consider all BDR topics, to be well-informed and prepared to put forward 3 strong BDR proposals as a commission for the 2023 session. If there are important realms of a BDR discussion that are not adequately addressed by the PPC and ex officio members present today, for example, if there's anything surrounding any budgetary impact, I would like the opportunity to gather research and provide that analysis to the PPC during the July meeting if that BDR topic is found to be one of the top proposals of interest to the commissioners. With that being said, I also wanted to give you an update of what is to come. Following this BDR discussion today, we are again collaborating with Baylor Health to deploy a second BDR topic web-based survey to all voting PPC commissioners. The goal of this next survey will be to allow all PPC commissioners the opportunity to notate their top 3 BDR topics after hearing all topics presented and the information fresh in mind. All commissioners will be free to vote for their own topic on this next web-based survey. Results of this next survey are planned for presentation and discussion at the July PPC meeting, which is currently scheduled for July 20th. This process will help the PPC narrow down the current list of 16 proposed topics to a more manageable number, with the important goal of arriving at a strong 3 by August. Again, if there are important realms of a BDR discussion that are not adequately addressed by the PPC and ex officio members present today, I would like the opportunity to gather the research and provide that analysis to the PPC during the July meeting. This way, the PPC may have a fully informed discussion surrounding these very important BDR topics. In addition to the 6 proposals that were presented during the May PPC meeting, we will now hear from the commissioners to present on all remaining BDR topics that were brought forward for consideration. Some of these topics may be slightly taken out of order just to accommodate some commissioner schedules. With that being said, we'll go ahead and go to the next slide, please. So this next proposal is a proposal to expand Medicaid benefits to all children through age 26. I included the previously discussed BDR topic of expanding Medicaid coverage to residents regardless of immigration status for reference, as the 2 topics are related. This proposal was put forward by Commissioner McAllister, who cannot be with us today. In her absence, I have approval to present this item for any further discussion, as it was initially presented by Commissioner McAllister during the March 16th PPC meeting. This proposal requests Nevada to expand Medicaid benefits to all children, adolescents, and young adults through age 26, no matter where they were born. Commissioner McAllister would like to note for the record, her top priorities are this item as well as telehealth parity when it comes to the BDRs. I would now like to open this item for any further discussion from the commissioners.
If I may use my prerogative, a quick comment on this before we get bogged down into detailed discussion. As you can all see, this implies major fiscal impact for the state. And perhaps it would be helpful before we delve into the pros and cons of this, to at least have a better perspective of the fiscal impact so that the discussion is more channeled and meaningful overall. So if the commissioners are okay with it, perhaps we could request some fiscal impact information from the relevant departments to get a meaningful understanding of this proposal. Is that the thought of the commissioners? Anybody has different perspective of coming back to this after we have more?
Commissioner Ralston, I see you have your hand raised.
I don't want to interrupt Chair Khan. I just wanted to address the comment earlier. Maybe I just wasn't clear that I didn't intend to forego my option to submit BDRs. I meant that I just didn't have, I didn't want to take the time to formally submit something for this meeting for discussion purposes only. It was my understanding that we were going to go over several of these topics and discuss, but there wasn't any voting today. And the purpose of me just not submitting anything formally was because I wanted to have an open discussion with fellow commissioners and a little bit more time to think about what I could formally propose that would either complement or maybe it's missing, but I didn't want to submit something and have any kind of duplicative proposals. I just hadn't had a chance to listen to all the other commissioners and speak to everyone. So I just wanted to take the time this meeting to really hear from the other commissioners on their proposals. So just wanted to state that for clarification that unless fellow commissioners have anything against me taking a little bit more time to possibly submit a separate proposal, I didn't want to just make it seem as though I don't intend to do so.
And that's fair, because we are not taking any voting or anything today. As I said earlier, this is more for discussion to narrow things down to more reasonable and feasible number of proposals. So
yeah, totally makes sense. That I just wanted to make sure that I stated that for clarity, but thanks so much, Chair Khan.
point well taken. So coming back to my original point, any commissioners want to give input today on this proposal versus getting more input from the state for fiscal impact? If so, please raise your hand.
Chair Khan, I did have a comment if I could. Quickly, I did receive some updated information from state Medicaid regarding the 1332 waiver. And if possible, I would like to read that comment into the record. This information was given to all commissioners, but I want to ensure that we all have the information at hand as we're speaking on.
Sure.
Great, thank you. So for Medicaid coverage of undocumented residents, a 1332 waiver of the Affordable Care Act would not be the appropriate federal tool because the authority under the 1332 waivers only applies to certain requirements that govern the exchanges, which sells qualified health plans, i.e. private health insurance to consumers. Although the language in Section 1332 of the Affordable Care Act appears broad as it pertains to state innovation in the state exchanges, including federal subsidies, it also does not permit waivers of Medicaid restrictions, nor does it permit a waiver of Subtitle E, Subpart B, which pertains to eligibility determinations in the exchange, including sections 1411 and 1413, which require determination of citizenship and lawful permanent residency for enrollment. Because undocumented residents are ineligible to enroll in the exchanges, they are also ineligible for the federal subsidies that can be used to reduce the cost of coverage. Simply put, states cannot use 1332 waivers to waive federal requirements for eligibility to provide affordable subsidized coverage through the state exchanges to undocumented residents. Currently, federal Medicaid funds may only be used to cover emergency services and as a state option for pregnant women and children, regardless of immigration status. Nevada recently took up this option to permit Medicaid coverage of pregnant women and children immigrants. Nevada could also consider a state-funded Medicaid option for this population, like California, as described below. California is pursuing a new slimmed down package of basic healthcare benefits, which includes preventative, primary care, behavioral health, and emergency care under its Medi-Cal program, or Medicaid, for young adults ages 19 to 25, regardless of immigration status. According to state officials, the state is only using federal Medicaid funds to pay for permissible emergency services to offset the cost of this new state-funded benefit. To make it lawful under federal law, the state must ensure no federal funds are used to cover the other non-emergency portions of this new benefit. Early estimates for this new benefit for young adults had a state price tag of $98 million, with the offset of the federal Medicaid share of emergency services making up only $24 million of this total. For Nevada to consider Medicaid coverage of this population, it could take a similar approach as California's new fully state-funded Medicaid benefit for young adults. The budgetary impact of state-funded Medicaid coverage, however, remains largely unknown at this time. Therefore, this proposal has the potential to be unworkable due to the fiscal impact to the state budget, given the size of this uninsured population in Nevada and the cost of Medicaid coverage generally, even with a slimmed down benefit for young adults as in California. Thank you.
Thank you. So that's extremely helpful. Good job, Melinda, to have gotten that up front. So that give a better perspective to the commissioners. Any quick comments from commissioners before we, this is self-explanatory, at least in my mind, unless somebody has any ideas, we can move to the next proposal.
Dr. Khan,
Yes, Babette.
I just would like to follow up, Melinda. That was very helpful. Thank you. I would like to just find out, can you, between now and the next meeting, find out how many undocumented eligibles there really would be in Medicaid? And do you think you can get any closer to numbers? I feel like from what I heard, the numbers you gave were the California dollars. So if there's anything that, I don't even know how many undocumented eligible members there would be in eligible residents there would be in Nevada. So I think that would be just helpful to add to this discussion. But I agree with the way you're going about this, Dr. Khan and Chair, and I appreciate it.
That's a very good question, in line with my thought process. That additional piece of information is crucial. So I agree with you. So Melinda, if you could kindly follow up and try to get us some numbers before the next meeting so you can share it with them before the meeting.
Yes, absolutely. Happy to, Chair.
All right. Any other quick comments in the interest of time? If none, we can go to the next proposal, Melinda.
Excellent. Thank you, Chair Khan. And I do see that we have Commissioner Flo Khan with us. Flo, if you wouldn't mind, we were going to skip down to slide number 13. Actually, it's slide 12. I apologize. To present your topic in the interest of time.
Thank you so much.
Yes, please go ahead.
Thanks, Melinda. And I do want to express my appreciation to the other commissioners for allowing me to jump out of line due to my unfortunate travel schedule today. So number 14, ensure pharmacy rebates are passed on to patients. This is a proposal that we've looked at that would have a direct benefit in addressing the prescription drug issue and prescription drug costs. And basically what it says is that currently drug manufacturers provide rebates and discounts to PBMs and insurers in order to get placement on the formulary. But they've done so also, but the main purpose of those rebates and discounts were intended always to go to the consumer, not to be used for PBM profit or, insurer profit. It really was intended, those were intended to help the patient pay for the cost of those products when the cost of those products went up. So, you would provide these rebates and discounts and they were supposed to be passed along to the consumer. That's what this proposal is really intended to do. It basically states that the rebates and discounts that are percentage, I should say percentage, it could be, the state could determine or anyone can determine whether it's, 85, 90, 100% of those rebates and or discounts would be passed along. But they really, the purpose is to state in this proposal that those rebates and discounts would be passed along to the consumer at the pharmacy counter. And so you would immediately see, patients would immediately see their cost reduced for those products that have rebates. Not every product has a rebate, but for those products that have a rebate, that they would be passed along at the pharmacy counter.
Thank you very much, Commissioner Flocon. Any comments from any commissioners on this subject? Please raise your hand.
I see Commissioner Bond.
Yes, I appreciate the explanation, Commissioner Khan. I think that the comments from not just the self-insured industry that we had public comment about, but also the commercial industry that I don't represent, is there's nothing in these proposals that actually changes the price of drugs. And in fact, these rebates, while the pharmaceutical industry is suggesting that they would lower the price of drugs, there's nothing to actually ensure that the insurance industry doesn't continue to pay higher and higher prices, which end up in higher and higher premiums, because there's nothing in these proposals that require pharma to actually reduce the prices that they charge. So it's like an artificial solution. It would be great for consumers to pay less, but the only sustainable way for consumers to pay less for their drugs is for pharma to stop charging so much and to reduce the cost of the medication. The rebates are a solution that was designed in the absence of affordable drugs. The rebates and the pharmaceutical industry are, managed by the pharmacy benefit managers as the only way. That is the only way to reduce the prices being charged, other than pharma actually lowering their prices. And pharma actually lowering their prices is a much better solution, because nothing in these rebates does that. And I think it's a kind of a cynical approach to price control, because they could just lower their prices.
I can appreciate that, Babette, and Commissioner Bond, and I would just say that there are these perverse incentives built into the system today, that when companies have tried to lower their cost of product, and they have tried that, particularly in the insulin market, those products don't get placed on a formulary. So there is a perverse incentive, because you know why they don't? Because they don't pay as much in a rebate. And so who controls what gets on placement on a formulary is a PBM and an insurer. And so when the PBM and the insurer, and it's largely the PBM, but when the PBM goes to negotiate with a drug manufacturer, they often require drug manufacturers to increase that wholesale cost of the product, so that list price, in order to get placement on the formulary. And then on the back end, they turn around and then they request a larger rebate or discount from the manufacturer, again, to get placement on the formulary so that patients can have access. And so there's this perverse incentive, and we agree, let's get rid of rebates. We would love that, but you need to do that at the federal level, because it's not just a state-by-state proposal or a state-by-state pricing. And so what we're trying to do is, in absence of getting rid of that rebate at the federal level, because that is being discussed and negotiated, but until that happens, this is the mechanism to help get to consumers quickly a discount on those products. And so I don't disagree with you, it would be easier just to reduce that price. But if drug manufacturers did that and they can't get placement on formulary, which is happening, then how does that doesn't solve a problem either. And so I think we're trying to find that middle ground right now that would help, in the absence of getting rid of this perverse incentive, which is these rebates, is to look for a way that would actually help consumers with their costs. And this does that.
So in the interest of time, any
I'm not, and it doesn't apply to Orisa. It doesn't apply to labor trust plans. It doesn't apply, it applies to the commercial market.
So thank you. So in the interest of time, any other commissioners have a comment, please raise your hand. Anybody else? Melinda, you see?
Beth.
No?
Commissioner Slamowitz, I apologize.
Okay.
That's okay. So I just had a couple of questions because, you know, this comes up quite often, this conversation about passing the rebates on to the pharmacy counter. I think the biggest problem with that is there's no transparency in the commercial market, right? So even if we are passing along rebates, how do we know what those rebates are? How do we know that they're actually being passed on? How do we know that the discount is actually being applied? And I do agree with, you know, Commissioner Bond in terms of it doesn't get to the core of the matter in terms of our drug cost. It doesn't affect or change the list price of these drugs that comes out. And I think that really is what's going to long-term impact, you know, drug pricing. We've seen a lot of manufacturers recently, even Medicare, come out and say that they've got set copays, you know, for insulin, $25. And while that's great for the consumer, it doesn't change the back end of that drug cost to the health plans. And so I know, like within Medicaid, we operate under a 100% pass-through type of methodology when it comes to setting our preferred drug list. And so we understand, the plan understands what those rebates are. We understand what the cost of the drug is, and we understand what the net cost to that plan is. And so I think until the commercial market gets to the same place where there's that 100% pass-through and there's the 100% transparency of what those rebates are and what the cost of the drug is, and ultimately, you know, what the consumer is receiving, I think, you know, to Commissioner Bond's point, these are not effective in terms of the larger issue of reducing drug cost.
And I guess I would just respond that right now the bill there's a similar bill that has passed in West Virginia. It's being implemented as of July 1st. I think we will start to see some data and how that plays out. And I think it's something to consider. If that, we know that there are rebates, there's over, at least we know that there's billions of dollars in rebates that are out there that are not necessarily being used to either reduce premium and or help consumers pay for the price of their medicine. So I think there we'll have some good data out of the state of West Virginia to show how this could work and if it will be of benefit to consumers. So with respect to the transparency piece, they are going to know. They're going to know how much of the rebate is so that they can pass that along. And they're doing 100%. So, you know, in West Virginia, whereas some of the other proposals around the country are at 90%. So I think we'll be able to see if it works and if it's, you know, beneficial to consumers.
Well taken. Let's look at for the data. Any other commissioner, because we are running tight on time because there are multiple other proposals to be discussed. Any other compelling question or opinion?
Bobette, do you still have your hand raised, or did you?
Yeah, I just want to close the conversation with, like, I guess this is repetitive. This is all in the absence of actually lowering costs, and the pharmaceutical industry has every opportunity to actually lower the cost of their drugs. And all these other things that you're calling perverse incentives have been created because of the list price created by the pharmaceutical industry in the absence of any sort of federal or state ability to manage it. And it's all, you know, it's all superficial fixes, and it's all supported and pushed by the pharmaceutical industry to avoid lowering prices. So thank you.
So thank you.
I appreciate that, but I think that's one opinion, and it's not, that is not the whole picture. And I can appreciate that everyone has a role to play in this, but you're just dismissing the role of the PBMs, the role of the insurers, the role of other players within the system. And we can disagree, and that's fine, and we will. But I think there's more to the system and how it operates. And until we are willing and able to look at all of that, this is a solution that will benefit patients immediately. So
as I said earlier, let's wait for the West, in my opinion, at least, wait for the West Virginia data, see if it really impacts anything. And I'll give my closing remarks as my prerogative to move on to the next subject. I'm really seriously concerned for decades, but nothing moves. The cost of medication, everybody knows, starts at the manufacturer level, and it's astronomical. And how it filters through rebates and managed care is a secondary issue. So that's my personal opinion. It really needs to be looked at. Everything needs to be looked at, but at the same time, the manufacturing cost and the cost to the consumer through the PBMs, et cetera, also needs to be looked at. So having said that, could we move to the next proposal, please? We have spent a lot of time on this.
Yes, absolutely. The next proposal is also Commissioner Flocon. Please go ahead.
Thank you. And again, thank you for allowing me to jump ahead. This one is really something that the employee groups and the employer group had looked at, and it really was eliminating the pharmaceutical deductible for patients who have a chronic condition. This is something that has occurred within the state of Nevada, within their own plan, just recognizing that those patients that have a chronic condition that need medication, if you eliminate the pharmaceutical deductible, they'll be able to have coverage for that medicine with their insurance from day one. And then as a result of that, people are able to more readily afford their medicine. Now, they still have to pay their copay or, a flat fee, if you will, but just eliminating that first, often $500 is kind of the average that we've seen deductible for these patients, allows them to get their medicine from day one of coverage, and then they're not having to forgo and then get into an emergency room or end up in a hospital that's 3 times more costly than if they just got their prescription drug on the front end. And so again, we saw this with the employee group. They decided to do that, and they said, yes, initially you saw an increase in cost because utilization went up, but overall they believe they're going to see a reduction in overall healthcare costs because people are actually appropriately adhering to their medicine and therefore not relying on more costly services.
Any comments from any commissioners? It looks like this part and the first part we were discussing probably could be looked at together in language distribution between the previous proposal and this proposal, both concerning pharmaceutical cost of products. So any other comments from commissioners? Any hands up, Melinda?
Yes, I see Commissioner Bond. Please go ahead.
I think some of my comments on the previous proposal apply here too. I think this is in the absence of the pharmaceutical manufacturers actually coming to the table and reducing those costs for consumers in the first place. These deductibles are in place to try to manage the cost impact of prices over the last decade. And so I would say that any of these proposals that are going to come to the table or even into the legislature, they need to be matched by a active reduction in the actual price from the pharmaceutical manufacturer in order for them to work. These are all being presented as one-way deals. Everybody else takes on the cost. The price never changes, and the pharmaceutical industry doesn't have to do anything. It all is coming out of somebody else's pocket. This is a second one like that. That's a pharma proposal that doesn't solve the problem. And additionally, I would like to say on this, I think if the employee and employers, Flo, I'm not sure who you were talking about in that group, if this is an effective cost management strategy and patient safety and patient health strategy, the plans are adopting these, and it shouldn't be a mandate.
Any other comments from any other commissioners before we come back to Ms. Flo Khan, to Commissioner Khan, to respond so that everybody has a chance to put in a question or observation?
Yes, Chair. I see Commissioner Rowe-Dugan. Please go ahead.
Yes, thank you so much. I agree with Commissioner Bond. I think that this proposal would just make the cost go to the insurance companies, which in turn will pass it to the customer or the patient. They may not have to pay a deductible, but somehow they will end up paying for it because the cost of the drugs are still going to be the same price. I think we need to either lower the cost from the pharmaceutical companies side or put a cap on those medications for chronic conditions, because at the end of the day, we're just passing the bill around, just like Commissioner Bond said.
Any other comments from any other commissioners?
Yes, I see Laura Rich, you have your hand raised. Please go ahead.
I do. I just want to point out that at least for high deductible health plans, there's IRS requirements around those deductibles. And so there's, you cannot necessarily carve out a deductible for, certain drugs and certain conditions because of those IRS requirements relating to high deductible health plans.
All right. Any other comments from any other commissioners?
I see Commissioner Bond, you still have your hand raised. Did you? Okay, excellent. Thank you. No other comments, Chair.
Okay, Commissioner Khan, you want to sum it up as briefly as you can, the comments made?
No, sir, thank you. That is correct. And in fact, the IRS has indicated that for certain conditions that you cannot have a pharmacy deductible because they do acknowledge that those patients need those medications. And so they've eliminated the requirement for a deductible. And so I think that the thought is that they want these people with chronic conditions to be able to access those medications because they know if they adhere appropriately, it will be less costly to the healthcare system overall. So those are the two proposals. I do appreciate all of you allowing me to present early so that I can catch a flight, but thank you.
Thank you very much, Commissioner Khan. Appreciate your input. The next proposal, Melinda.
Yes, thank you, Chair. Next, I would like to go to Commissioner Slamowitz on slide 14, as we also are working to accommodate her schedule as well. Commissioner Slamowitz, please go ahead.
Thank you. So the BDR that I'm presenting is to increase access to naloxone. Currently, naloxone is a prescription required medication. Nevada has done a lot to increase naloxone access, including passing laws, executing orders to simplify the prescribing and distribution, essentially trying to make the drug an over-the-counter and accessible to people in Nevada. But I think there's still more that can be done. A lot of the information and conversations that I've had, especially with harm reduction programs, has shown that the access to naloxone, as well as the cost and other issues, are still keeping naloxone from reaching its saturation point across the state as well as across the nation. We're still very much in an opioid epidemic. We still overdose is a public health issue. And so what I wanted to do is just kind of present some of the issues that I've seen and maybe offer some potential solutions. So harm reduction programs are our first line of defense to preventing overdose deaths. They're adept at reaching marginalized communities that mainstream medicine and public health cannot. They've distributed naloxone that lay people have used to reverse hundreds of thousands of overdoses. Unfortunately, their ability to quickly and effectively get naloxone to the people who are most likely to reverse overdoses continues to be hampered by legal and regulatory barriers. These barriers slow down and sometimes prevent entirely the purchase of naloxone. Currently under Chapter 453C of the NRS, harm reduction programs pursuant to a standing order from a properly authorized prescriber can store and dispense naloxone, but they are not able to purchase naloxone directly. Even though Nevada has done a lot to increase naloxone access, there are still significant barriers to the purchasing of naloxone by community-based programs. Currently, there is no statewide standing order in place. In order for these community partners to purchase naloxone, they have to have a standing order in place with a medical prescriber, often who they do not have on staff. And so that does create a barrier for them to utilize the current pathways in order to get naloxone for their patients. Naloxone availability is extremely variable. It's been found to be inadequately stocked in areas with high overdose rates, minority neighborhoods and areas with low average household income. One reason for this lack of availability could be the result of a phenomenon known as medication deserts, a term that describes areas where geographic access to pharmacies is severely limited and the stock at these locations may be insufficient to meet patients' needs. In poorer districts where people who are unlikely to own cars live, pharmacies have a greater chance of not having medication stocked in comparison to those in more affluent areas. Pharmacies also face the issue of family and societal stigma, which causes a lack of demand and often leads to pharmacies not carrying the medication, even in areas where the population is present. Some of the other issues that these harm reduction programs have seen, large pharmaceutical manufacturers such as Pfizer require DEA registration of the prescribing physician, even though naloxone is not a controlled substance. In their ordering system, one prescribing physician cannot provide their DEA authorization to multiple harm reduction programs, thus rendering even statewide standing orders useless for naloxone procurement. Smaller generic manufacturers also require physicians working with harm reduction programs to sign affidavits, clarifying that their naloxone prescription explicitly authorized purchase and not solely distribution. Corporate compliance officers require this burdensome paperwork to document the transaction out of fear of FDA enforcement. Distributors do not have a model for situations of state OTC versus federal prescription descriptions. For example, a convoluted fix was necessitated by the fact that prescription product division, McKesson Pharma, is a separate commercial entity from the medical supplies division known as McKesson MedSurg. And syringe service programs are ineligible for McKesson Pharma accounts because they are not pharmacies. Therefore, naloxone has to be transferred between these divisions, creating delays and additional supply chain vulnerabilities. In terms of charitable donations, in order to receive a charitable donation of no-cost naloxone, programs must meet compliance requirements dictated by prescription-only status. To receive free naloxone through Direct Relief, which is Pfizer's donation of 1 million doses program, programs must comply with State Board of Pharmacy regulations in storing and dispensing medications and have a medical director or a pharmacist with a valid state license. Recently, the Buyers Club received a separate commitment of a 50,000 dose donation for members' programs, and only 3 programs were able to produce the required paperwork to receive an emergency donation. The Buyers Club, for those that are not aware, was styled after early AIDS antiretroviral purchasing groups. It's a collective of more than 100 organizations comprising the backbone of community-based naloxone distribution in the United States. The primary purpose of the Buyers Club is to facilitate the purchase of naloxone. For nearly a decade, the vast majority of community-based naloxone distribution has quietly relied on this arrangement. Programs place orders with the Buyers Club, which are batched weekly and sent to Pfizer. Pfizer ships the naloxone to programs who pay Pfizer directly. It is an unfunded volunteer effort and does not impose any fees. In addition to placing orders, the majority of staff time is spent on assisting programs and filling out the substantial paperwork required by the manufacturer because naloxone is designated as a U.S. Food and Drug Administration, FDA, to be prescription only. So while we cannot necessarily change all of the supply chain issues or address the federal regulation in terms of it being prescription status, hopefully that will change soon and it will move to an OTC status. There are ways I believe that the state can support and perhaps look at expansion of naloxone and increase the saturability across the state. Financial support for naloxone. Half of the Buyers Club programs report having to do fundraising to purchase naloxone. GoFundMe pages, t-shirt sales, and donations to overdose memorial funds are very common. A quarter of the programs report regularly rationing naloxone due to inadequate support from state and federal government. Half of the programs do not receive any financial support to pay for staff time to distribute naloxone and manage the paperwork required in order to get the naloxone into their programs. In 2021, the White House put out model legislation for increasing access to opioid antagonists. Included in that model legislation was a section on funding. This included federal funds, grant programs, additional sources such as gifts and endowments, as well as state funding for services provided as part of increasing access and obtaining emergency opioid antagonists. To maximize impacts, high-value naloxone access laws should explicitly counter existing healthcare system inequities, address stigmatization of opioid use in naloxone, maintain reasonable prices for purchasing naloxone, and target settings beyond community pharmacies to distribute naloxone. Part of my BDR recommendation is looking at the possibility of creation of an opioid antagonist access advisory committee that would look at and bring together all of the stakeholders across the state, including pharma, our retail pharmacy chains, the Board of Pharmacy, to look at how we can increase access and purchasing of naloxone across the state. We need to increase and expand where we purchase and how we purchase so that we can get naloxone to these harm reduction programs and our community providers where it is most effective. Thank you.
Thank you very much. I appreciate that. A quick comment before we open for discussion. If I may request the commissioner, since everybody has had the opportunity to review these proposals as recommended by the various commissioners, would be helpful if in our today's presentation, if we highlight the essence of our proposals in the interest of time, because everybody should have had a chance to read them and develop their thought processes, pros and cons, and gives more time for questions or observations for the commissioners proposing to be able to answer for a more meaningful debate. So having said that, any commissioners raising hands for questions or observations?
Yes, Chair Khan, I see Commissioner Bond. Please go ahead.
Hi, Commissioner Slimowitz. I just had a quick question. I know the AG has a substance abuse group, and I wonder if this has been part of those discussions. I haven't tracked those discussions. I don't know how this would fit together. I just would like your thoughts. It's a great issue. I'm glad you brought it.
To be honest, I haven't tracked those discussions either, so I'm not sure in what capacity, naloxone or naloxone access has been discussed. But I'd be interested to know that as well. I think the biggest, issue, and I have had some conversations with the State Board of Pharmacy in looking to see how we can work within the constraints of the federal requirements to allow these community-based providers to be able to purchase directly through wholesalers or manufacturers to increase the access.
Any other questions or observations?
Chair, I'm not seeing any at this time.
Okay, thank you. So we move on to the next proposed BDR.
Excellent, thank you. I would now like to move to slide number 7, if we could, please. So this topic was submitted electronically from Commissioner Winkler as a primary topic of interest on his behalf for the PPC's consideration, sorry. And I just want to read his notes into the record. He wrote, "In my absence, I hope to provide some background and justification for one of my BDR topics we have not yet discussed." So this one is to create prescription drug and health plan review boards. For the sake of brevity, I will follow the guidelines provided by Melinda Southard. A summary of the proposal is a prescription drug health plan affordability review board gives states the ability to limit how much its residents pay for certain high-cost drugs and the affordability efficacy of health plans available. Costs and plan coverage involve many complicated issues and affect numerous stakeholders. A drug affordability review board would bring the parties together, increase transparency, and set an upper payment limit cost-sharing arrangement. How this aligns with the PPC is that it would directly address accessibility, affordability, and quality of healthcare, as well as leverages the Peterson-Milbank cost growth benchmark. Why it is important for the PPC to consider as a topic, several analyses have shown prescription drugs to be one of the main drivers of cost growth. In several states, there has been significant interest in legislation to further regulate drug prices, and it offers an opportunity for a coordinated strategy. Affordability review boards follow directly from the data we are collecting and analyzing as a cost mitigation strategy to ensure the benchmark strategy is successful. If the BDR topic has a budgetary impact, I asked, please provide suggested detailed revenue source to complement the topic. And Commissioner Winkler wrote, if these boards would function similar to, or perhaps as part of the PPC, the cost would likely be nominal or could be assumed by the appropriate state agencies. Thank you for your time. And that concludes Commissioner Winkler's presentation.
Thank you. Any comments and observations on this?
Commissioner Slamowitz, please go ahead.
So I just wanted to provide one quick comment in terms of these affordability boards and, you know, what I've seen in other states and what I recognize has been the effort in terms of the transparency program that the state has operated is that these boards are very labor intensive and they also require an adequate avenue of data in order to support those the costs that are determined to be kind of the ceiling. And so I think that there's a lot of thought that needs to go in these in terms of support. I think I disagree in terms of the financial impact. I think there needs to be fiscal support for something like this because of the labor intensive process that's involved in doing this. And I know that that prescription drug affordability boards have been brought up in the past and have failed for various reasons. And so that would just be, I think, ultimately my concern is that those items are addressed in terms of what is really truly needed in order to operate a board of this type.
Thank you, Commissioner.
Any other comments?
Yes, I also see Commissioner Bond. Please go ahead.
I have two quick comments. I appreciate Commissioner Slimowitz's comments on this. I think this is one of the areas where it would be good if we could get some fiscal information about this. I appreciate that these boards can't operate without resources. And I agree that they haven't been super successful, but I would like to make 2 points about that. I have been really compelled by the information that's coming out of the benchmarking program and the hopes that the all-payer claim database have, where we're going to have some data in Nevada. And then this is the kind of stuff you would do with that data, right? Have an affordability board that can review it. Or so I feel like those go together. So I feel like the data is going to get resolved. I think the resources are an issue. But I would like to understand better the fiscal needs of the board. The other reason they failed is because there's been lawsuits filed by the pharmaceutical industry. And I think that we just need to acknowledge that and see, you know, if there's a way for the state of Nevada and LCB to design one that would be less likely to be sued. But, you know, that shouldn't have the chilling effect that it has on moving forward with affordability on A. On B, I'm only compelled to say something because Helen Foley spoke during public comment about the commercial health insurance plans. And I don't want that issue of the 17%, I think she said, of what is impacted on commercial markets to be the lens that we see everything through here, because in fact, the commercial market, which is Aetna and United Health and Anthem and, you know, the big health insurance plans that operate in Nevada, when they design plans that self-insured companies use, like MGM, like Caesars, like, you know, private companies that are creating a self-funded plan, they use a commercial product often. When they do that, those commercial plans are the ones being used by the self-funded market, and those are not numbers that are included in the 17%. So I think it's important that we get an accurate count on what really impacts the commercial health insurance plan. If there's a mandate that is presented and they have to comply with it, it actually does move into the self-insured market because they're a big presence in the self-insurance market as a vendor, and those mandates go with that market into the self-insured payers. And I don't think that's described often. And I think that we should make sure that we understand the impact that has on change in the commercial health insurance plans.
Thank you, Commissioner Bond. Any other comments?
I'm not seeing any additional comments, Chair.
All right, thank you. So we move to the next proposed BDR.
Excellent, thank you. If we can move to slide 6, please. So this next proposal was also put forward by Commissioner Winkler. In his absence, he has again given approval to me to present this topic on his behalf. This proposal requests to permit access to Nevada's private insurance marketplace, the Silver State Health Insurance Exchange, regardless of immigration status. And I did just want to note that there were some comments that were covered regarding this BDR topic in slide number 5 regarding the Medicaid expansion. And with that, I'd like to open it for discussion. Commissioner Bond, did you have your hand raised again? Okay, that's okay. All right.
Anybody else has an input?
I am not seeing any, Chair.
All right.
Oh, apologize. Commissioner Ralston, please go ahead.
Yeah, I know that Commissioner Winkler is not here, but I would like to just see if he can give us additional follow-up and context to, you know, what this looks like and what the legal parameters are and why they're not able to access it currently. I think just some more background information would be good for my edification. That's all.
Excellent. I can take care of that for you, Commissioner Ralston. Thank you.
Anybody else?
Not seeing any, Chair.
All right, so moving right along to the next proposal.
All right, if we could move to slide 8, please. So this next proposal is to address healthcare market consolidation. I would now like to hand it off to the commissioner who proposed this topic to present and then open for discussion.
Was this me? This is Bobette Bond, sorry. I'm gonna get back on screen.
No problem, Commissioner Bond.
Oh
Unfortunately,
yeah, this is mine. I'm sorry.
okay, good.
I'm sorry. Let me get on screen here. Oh my
Okay.
God. Okay, so I didn't know we were doing this one today, but I appreciate the opportunity. So before I do that, I'm having a thought that maybe we could talk about Dr. Khan, Commissioner and commissioners. At the end, maybe the ones that didn't get represented today, people can provide a summary of what was in them so that everybody has refreshed info, you know, going into review of these after the meeting. This is a bill to address an issue that's happening in the community. There's supposed to be a requirement in the state of Nevada that physicians cannot be hired by the hospitals. And the reason for that is, in particular in a state with such low density of physicians, if a physician is a specialist like a cardiothoracic surgeon and he is hired by one hospital, then the rest of the hospitals that need cardiothoracic surgeries care in their hospital don't have access to that physician. And if there's only 2 in the state or 2 in the area, it ends up being a real barrier to care and access to care for the rest of the hospitals. So that's kind of the basis for why there's this strong law in many states about physicians not being hired by the hospital themselves. Nevada has that law in place, but it's gotten confused over the years by a combination of opinions by the AG and the move into Nevada by the Nevada Cancer Institute that needed an exception. And I think that what I would like to do is present an opportunity for this bill from the PPC to clarify that, in fact, there is a prohibition on physicians being hired by the hospitals themselves, because it's only increasing our shortage of care access. And secondly, the exemption that existed for community hospitals and academic institutions should be clarified to be just that, so that those hospitals still have the ability to hire who they need. And that's an exemption that existed in the past. So it's a muddled law now that needs clarification, because in the absence of it, the hospitals are hiring these physicians and it is creating more shortages for care in the hospitals that don't have them.
Thank you, Commissioner Bond. Any comments, observations from commissioners?
I am not seeing any at this time, Chair.
A quick, anybody? No? So a quick comment on from a provider perspective. This is a double-edged sword in the sense that while there is an acute shortage of physicians in Nevada, as was alluded to earlier, and that's been a discussion at the state level for years, as long as I can remember, sitting on various commissions, boards, et cetera, task force, and it never gets addressed. The answer has to be somewhere in between, where the physician shortage is taken care of. At the same time, access is made possible for the common patient in the community. So I think personally, this needs to be carefully looked at, reviewed, so that we don't have some unintended consequences of this scenario also. So it's worth reviewing carefully to address the shortage of the physicians also in the community, and at the same time provide access to the patients that they need that. The shortage is really acute. I think at one of our previous commissioners meeting, I had mentioned that at great length. And there was a long discussion between one of the other provider physicians at that time. So from a provider perspective, I think this needs to be seriously reviewed and looked at and studied and carefully gone over. So that's my view and rather observation on this. Any other comments?
Thank you, Chair. I am not seeing any other. Oh, apologize. Commissioner Ralston, please go ahead.
That's okay. I'm really interested in this topic and further discussion of it as a way to kind of help rein in the prices for patients. And really this, although I do understand what Chair Khan said about unintended consequences, I do think there is a lot of concerns around kind of market power abuse that really affects consumers' prices and access to care. I know the commission heard from, I think it was Professor Jamie King a couple years ago early on, who talked a little bit about this and what other states are doing. So perhaps a recirculation of her presentation to the commission would be helpful for further discussion. I just wanted to throw that out there, but I'm really interested in having a deeper discussion about this, especially how it could positively affect patients.
Thank you. Do we have Commissioner Van Houweling from the hospital side on the line still?
Yes, Dr. Khan, Chair Khan, I'm still here. Yes.
Yeah. Do you have any thoughts on that?
Well, it's certainly, as Commissioner Bond mentioned, there's currently existing laws on the books that are certainly need to be reviewed. She's correct about the AG's opinion on that, and I think that's something that we should revisit regarding the AG's opinion and with this administration and with our current AG. But it's certainly being tested. It does create issues in the community when you have certain subspecialties such as pediatric surgery and some of these very unique services where we only have a handful of particular providers for millions of individuals. So when those individuals come off the market, if you will, because they're attracted by a compensation package or only operating at one hospital, that puts stresses and demands on the rest of the community. And quite frankly, it limits access, and that's what this commission's all about. I think that's what Commissioner Bond's concern is having the availability for everyone, regardless of what side of town they live on or what community they're living in or what hospital they choose to. So it does definitely put a strain on the market overall. And so I think we need to look at it at the existing laws today, make sure that we're complying with those laws. And then, as you mentioned, how do you strike a balance of meeting the demands and the needs, but also addressing that shortage in that specialty? So I think this is a good one to look at, and from what's on the books, but also how do we tighten it up a bit to ensure that rural communities, and I'm just not talking Las Vegas. We're rural communities, out the frontier communities in the state of Nevada, but also very large cities like Las Vegas and Reno that has the demand. And as you heard from Mr. Kelly earlier, we're already short 1,500 doctors just to get back to the average. So, and then when you get into these subspecialties, it creates a huge strain and stress. And quite frankly, that's why people leave our community. And I think we all want to keep Nevadans in Nevada. So I agree with everything that's said. And this one's definitely at the top of my list to dive in as well. So I'm glad we're talking about it.
So a quick comment to follow up. There are two challenges as I see. One, the physicians that move into Nevada, especially the rural areas, it's been a challenge forever. No doctor wants to be based in the rural areas. They end up being in the quote unquote catchment area. For example, Reno, for some of the counties beyond that, that will have had a huge challenge having access because the physicians choose not to be in certain locations for various reasons, family reasons, personal reasons, social reasons, and certainly economic reasons. Same is happening in the urban population, where the physicians, just given the growth of the town, have chosen to be working out of certain hospitals only because they don't want to run around all over town. So, and this has changed since the time I moved to town. I used to go to every hospital, and towards the latter part of my practice, I cut it down to 2 hospitals. I just couldn't keep up running around to various hospitals. So that's the other dilemma in the private sector. How does one address that where the physicians may choose? In my case, it was a surgical specialty, but I wouldn't go to all the hospitals anymore and just confine myself to hospitals for my convenience, for my patient follow-up, et cetera, not being stretched too thin. So that is the other element of physicians choosing also to practice to restricted facilities in the urban population. So all this needs to be kept in mind. So it's a good discussion. Any other comments?
Yes, I do see Commissioner Bond. Please go ahead.
I'd just like to wrap up. I appreciate the conversation. I think to your point, Dr. Khan, I don't think that the intent of this legislation is to impact what a physician chooses to do or where he chooses to practice. I think this is about the hospitals cannot hire the doctor to only practice there. If a physician doesn't want privileges at that hospital, he doesn't have to apply for those privileges. I don't think this law would limit the physician's ability to operate wherever he wants. That's not the intent of it. I think it's more to make sure that the physician isn't tied to one hospital by the hospital through a contract with that hospital as an employee.
Got it.
Thank you.
Thank you, Commissioner Bond. Any other comments on this subject before we move to the next one?
Commissioner Van Helling, please go ahead.
Yeah, I think Commissioner Bond's point is well taken. And if you think about the market and the economy, and obviously we like those conditions because it does create competition to drive down prices and increase access. But if you really think about it, the facilities or the providers or the entity, their institution that can afford these particular, CBT was one, but you can go down the list, whether it's peds surgeons, neurosurgeons, you can go down the list, and we need to at least create an environment that allows that access. And Commissioner Bond's exactly right. If somebody wants to limit their schedule or their day and only choose to be credentialed at certain hospitals, that's been in the market and that works well. But when you take players out of the game and you limit that, that's where it creates these economic conditions and then drives up prices, drives up the need to rely on providers outside the state. And that's one that we're currently focusing on. And they come in and they're not as vested in our communities or our population. So they're just kind of temporarily here. And so whoever, has the most money or has the ability to afford a particular provider, and that drives up the salary cost and also gets passed to a as Commissioner Garlini mentioned, that gets passed on to everybody, right? At the end of the day, it's passed on to consumers. So that's who we're all trying to protect. So I love this conversation because there's a lot of pieces and moving parts to it. But, I think we definitely need to look at the existing laws on the book, make sure that we're complying with those. And I would ask that our council and the department's oversight of that is looked at. But how do we encourage more providers to come to our state and compete in a free market?
Thank you, Commissioner Van Houweling. Any other comments before we move to the next one?
Yeah, I do see Commissioner Bond. Please go ahead.
I just want to wrap up. I appreciate Commissioner Van Houling's statement. I just wanted to say, just to remind the group, there is a law in the books now, and there's just been inconsistent use of that law. And I think that that's what we want to do. We want to make sure the public hospitals that are responsible for taking care of everybody have whatever resources they need to do it, but are not taken out of being able to provide services by doctors being hired by one hospital. So that's it. There's clarification in the law that's needed, but it's not a crazy notion. These laws exist in most states and for good reason. Thanks.
Thank you, Commissioner Bond. And if no other comments, we can probably move to the next proposal.
Correct. No other comments, Chair. We'll go ahead and move to slide 9. So just this next slide. This next proposal is to require transparency of healthcare cost data. I would now like to hand it off to the commissioner who proposed this topic to also present and open for discussion. Is there anybody who wants to own this topic?
Do you know who proposed it?
I think it was me. I was not prepared. I'm so sorry. Okay, so this was a long time ago when I sent it. But basically, I think we need some either DHHS to oversee and make sure there's transparency between what the hospitals are charging or what the insurance companies are charging the patients. So what I found out is that in California, they have a lookup tool that was required by Congress in the 21st Century Cures Act. And it's only for certain procedures where they show the price of the procedure. So the patients can go up to this site and compare apples to apples. So of how much they would pay if they have this procedure done. My suggestion is to do this for not just certain medical procedures, but for everything. How much would be the cost of stay in a hospital? How much would be paying out of pocket or with the different insurance that the patient has? In order to do this, we would have to mandate that the medical facilities be transparent in telling either DHHS or the board or the government body that is going to create this site to have the correct pricing for these procedures or treatments at each facility.
Thank you. Any comments, observations on this? Anybody raising hand?
I am not seeing anyone, Chair.
All right. Okay, I'll have a quick thought process. I'm just looking at it from based what was said. So this is a very complex and complicated scenario of coming together with the cost of a procedure, because a procedure, if it's a surgical or invasive procedure in a particular facility or outpatient surgical center, there are multiple components to it with each particular entity. Number two, each particular entity also has various negotiated rates for the same procedure or hospitalization within the marketplace where they are in the free marketplace. They negotiate with each particular entity or facilities. So all of this has to be kept in mind before any meaningful data would be even available to come to that. Now, there are some marketplaces around the country where they are more sort of, I call it commercialized, where to attract business, they'll give a lump sum price, for example, for a particular procedure, $10,000, everything included, and the patient comes in, gets that procedure done, everything included, for example, $10,000, and then he or she gets a complication out of that procedure, and now the clock starts ticking, and they come back with all those complications, and the cost keeps going up and up and up. So it's, in my opinion, it's easier said than done to give a price quote of a comprehensive price quote, and then following that to predict or project, well, if there's a complication, it'll be this. If there's no complication, it's this. It just doesn't work that way in other places. But some of the commercial places, outpatient surgical centers are doing this, where they give a lump sum price. And if the patient gets a complication, they tell them, go to the hospital. We are just a surgical center. So that's not good medicine either. So just my thought, just at a glance.
And I did want to just pass it to Commissioner Bond. Please go ahead.
Are you on mute, Commissioner Bond?
He's on mute.
Sorry, I'm saying, I understand what you're saying, Dr. Khan. Now that I've listened to you, you're saying that even these tools don't always provide equity, because what a hospital provides is so much more comprehensive if there's complications than what a freestanding ER would provide. But on a piece of paper, it looks like the freestanding ER might be a much better deal if the database isn't presented, you know, with a lot of thought. I do think, though, given how much work we're doing on the all payer claims database and the work that Bailiff's doing about this, the stuff we're trying to get off the ground with the benchmarks, and there's a lot of federal laws going into place about transparency, hospital transparency, and health plan transparency. I would like to just hear from DHHS about what they think is already available, and if there's any way to start working towards what Commissioner Yerlani, I'm forgetting, I'm sorry, Roa Dugan's, you know, proposal here. I don't know if there's other ways to do it, or if there's already pieces in place, just to do the research on the next steps. Thanks.
Okay, that's very helpful. So we'll have some of that information at our next meeting from the DHS. Any other thoughts on this proposal?
I would like to add something. So if we take into account, how do the insurance companies decide the pricing for the procedures? Could we use that as an example? Because they have a tool. They're gonna say, okay, if you're having vaginal delivery when you go to the hospital, this is how much it's gonna cost. Then the price can go up if there are complications. If you are having a cesarean section, this is how much it's gonna cost. The price could always go up depending on the complications or whatever happens. But there is a starting price. And I think we could give this information to the patients so they can make a better and informed decision of where to go, especially those patients that if we can't do anything about giving them access to private healthcare, which is our big number of undocumented Nevadans, then this would be an option for them instead of waiting until they go as an emergency to the hospital and then nobody pays.
Commissioner Bond, would you have any thoughts on that, since the request was about how this managed care entities do this?
Yeah, I do think that there's some price transparency coming out that's mandated by all the health plans that are Orisa and commercial. So I'm just wondering, again, without putting, you know, tons of dollars into new data, I really do think DHHS might have some starting place here. Maybe there's a way to do it through. Can DHHS weigh in here on options? Because I think it's a legitimate issue. I don't know if we have the resources to do it in managed care without dollars, but I would like to hear if DHHS has ideas about how to tally what's already publicly available into a more usable form.
Okay, good. So why don't we table further discussion based on the DHS presentation?
Chair Khan,
Yes.
I did notice that Director Whitley did have his hand raised. If you want to go to him for comment quickly.
Yes, please.
Excellent. Director
Sure.
Whitley, please go ahead.
Sure. This is Richard Whitley. And I do think to Commissioner Bond's point, I think that we have infrastructure already created out of the last session where we combined the work being done for balanced billing between health plans and hospitals and our Office of Consumer Health, which serves to inform the public. We already have a synergy there. And so I do think there's opportunity. We can do some more detail on what the cost might be to add this transparency, but I think it would be far less because we have the capacity already existing.
All right, thank you, Commissioner Whitley. Anybody else before we move to the next one?
I do not see anybody else. Thank you, Chair.
Thank you. Do we have any more proposals? I lost track of them.
No problem. We have 2 more remaining proposals. So this next proposal is on slide 10. It is to prohibit certain provider billing practices. I would like to hand it off to the commissioner who proposed this topic to present and then open for discussion.
This is mine also. This is in requests that we've gotten in our Health Services Coalition, which represents 25 different health plans. And we are trying to figure out ways to reduce the price of care when it's not actually providing care. So it would reduce prices without reducing services, because some things are being charged that just don't have anything to do with care. And so we would like to consider a proposal that would prevent providers from billing patients for things that are not related to care. Medicare pays for physician care that happens at a facility. If the physician has a freestanding office on the property, I'm sorry, I'm not presenting this really well, but there's a problem, right? There's a problem that we're seeing with costs on several. Let me give you three quick examples because I'm not explaining this very well today. If you're a physician and you practice on your practice is on in a medical office that you've constructed or that you operate in, there's something that you can charge for your care. But if you move that facility onto a hospital property and a hospital facility on their campus, then you can add this facility fee that is a big increase in price, but doesn't provide actually any care for the patient. Sorry, there's just added cost for that care. So that's an example. The second example is doctors and care providers. We've gotten a lot of complaints about this, that charge a patient, $100 to fill out their loss of time forms, even though there's no care being provided. We'd like to see if there's a way to manage that better, because there's no limits on those costs for patients when they're out of work and they need help with their forms. And I understand there's also costs on the provider to provide that services. So where's the medium, right? And then finally, there's these trauma activation fees that get charged for patients who enter a trauma facility, even if they don't need trauma services. And they can be extremely excessive. So we're trying to figure out if there's a sweet spot here for what cannot be billed to a patient as part of care when there's actually no care.
Any other comments from anybody else?
Commissioner Van Houweling, please go ahead. I think you're on mute.
Sorry, can you hear me now?
Yep.
Yes.
Trying to avoid that buzzing noise that always happens with me. So, no, I think this particular one is of interest, especially that last portion of being a level 1 trauma center, which is very rigorous, lots of due diligence and demonstrating to the community and the American College of Surgeons that you've earned that designation and you're committed to the community. I certainly feel that that if somebody's not designated a trauma center, they shouldn't if they're not, they shouldn't act or pretend one to the community, and they certainly shouldn't charge the levels of what that is commitment to and the resources that are required to do that. So I think there's a lot of hospitals in the state of Nevada that are pushing those limits or far exceeded them without actually having that designation. And we want, although more sounds better, right? Everybody wants a trauma center, but not in this particular case. You want the best of the best. You want the experience, and that people do it that day and night. So I like this particular last portion, just because I've seen where in other facilities, patients have gotten very large bills, but they are not truly designated a trauma center. And I think the state and the local health district has done a good job of making sure that facilities earn that designation and that they're committed, that they're not getting in and out of it. But I agree that some of these costs are at the level of a level 1 trauma center, or sometimes far exceed the level 1 trauma center. So just my comments.
Thank you, Commissioner. Is there any other comments for this topic?
This is Dr. Khan, so I have a quick comment following Commissioner Van Holling's input. There is a lot that gets involved in the preparation and arrival of a potential trauma patient, and a true trauma patient, not what we, in my opinion, call level 3 or non-level people who are considered these as trauma charges or activation charges. So the activation process, and Commissioner Van Holling can elaborate that, is a significant undertaking under the requirements of American College of Surgeons, et cetera, which are required to get ready for this patient. Whether this patient arrives or gets diverted someplace else, or the patient passes away in the process, or the patient arrives and does not need necessarily full services, even though that was anticipated. But that's a part of doing business and the nature of the beast of trauma. So certainly there has to be an element to cover those cost bases of level 1, 2 trauma facilities. Level 1 is the trauma facility, which has full teaching service program available with trauma residents, et cetera, or fellows being taught. And level 2 is everything minus the teaching activities that go with level 1. Then there are level 3 who are just, in my humble opinion, are triage centers that bring the patient in, that see the patient, send them to a level 1 or 2. And that triage, in my opinion at least, is not a trauma activation rather than just an ER visit. So these are the things that need to be carefully looked at before we get into this process of charges for activation for trauma services, whether it's appropriate given the level of trauma designation. Any other comments from other commissioners?
Not seeing any, Chair.
All right. How about the last item, Melinda, finally?
Yes, the last one. All right. This next proposal is to review insurance benefit design and cost sharing. I would like to hand it off to the commissioner who proposed this topic to open for discussion.
Are we on mute?
Do we have anyone who wants to own this topic?
Who's the commissioner who proposes? Do you know?
So unfortunately, I do not. Since Leslie is out, all the topics were sent directly to her, and I do not have access to that. So
Somebody is owning up in the next 15 seconds, and we'll table this. Maybe somebody will own it up next time. All right. So moving right along. So that brings to a conclusion of this pretty exhaustive discussion. We covered, I think, about 12 items today, which was good. And now running into our possible ongoing discussion of overview of Nevada healthcare quality performance data and discussion of potential PPC recommendations is item number 5 by Michael Bailiff. And we have 35 minutes, Mr. Bailiff, including questions and observations of the commission. So please keep that in mind.
Quickly, Chair, if I could, I did notice that Commissioner Ralston has her hand raised.
Okay,
So thank you so much, Melinda and Chair Khan. Just I will have to jump off within the next 15 minutes. So I just wanted to make that announcement. But I also just wanted to put in a request if we could, just for process kind of clarification as the commission continues to discuss these potential bill draft requests, if we could have a process in which they're grouped by subject and then maybe reviewed by the attorney to see if they properly fit kind of the single subject rule. I know that Nevada has a state mandate that all proposed legislations have to fit within or embrace one subject. But I do think some of the discussions today and the ones prior could potentially fit into one subject. And then if we go down the process of narrowing down what stays in and what doesn't, because a lot of this to me seems a little bit, I mean, there's a lot of proposed topics, but they're done by line items and not by subject. And so I just think that it would be a little bit more efficient if we discuss these in terms of subjects, because some of them could go into one proposed bill draft request. And so unless commissioners feel otherwise, I just think that that would help the flow of our discussions and, you know, ultimately leading to a process in which they're being voted on. So
that's a very good idea. So let's follow through this. I fully agree with that. They'll streamline things and also bring them into compliance with the requirements of how the BDRs are put together. So having said that, we now go back to Mr. Bailiff? Yes?
Yes, thank you, Chair Khan.
Right, thank you.
So we're going to transition. I want to invite you all to stand up and stretch because we've been talking about those BDR topics for a long time. And you can do so while I introduce this topic. So as a reminder, during the March meeting of the PPC, there was a request by members to receive a presentation on state performance on measures of healthcare quality. And so in order to respond to that request, we carried out the following exercises. First, we looked at quality performance measures that are reported by the National Committee of Quality Assurance, which is the accreditation body for health insurers. And we look specifically at state performance in both the commercial and Medicaid markets on a sample of measures that are reported by the National Committee of Quality Assurance, otherwise known as NCQA. And we compared performance of Nevada's insurers, or I should say a sample of the largest insurers in the state, in both the commercial and Medicaid markets to NCQA's Quality Compass database, which includes national benchmarks for health insurers in the country. So that's the first thing that we did. Our second analysis was to look at overall Medicare star ratings and patient survey ratings for the largest hospitals in the state using Medicare's Care Compare tool, which is an online tool accessible to all of you. The Quality Compass database for NCQA is not publicly accessible. You have to pay a pretty hefty license fee for it, but we previously had done so we were able to access it. The Medicare Compare tool, however, you can all access online. Any questions about what we did for this analysis before I begin to share the data with you? Okay. So for Medicaid performance, we calculated a 2020 enrollment weighted average for 3 Medicaid managed care plans that were contracting with the state to provide Medicaid managed care services during this time period. You are all aware that 2020 was a year in which service utilization was certainly aberrant, but that was true in every state. But I will note, though, that the absolute rates for a lot of quality measures declined nationally because of a reduction in people accessing care, particularly early in the year, most dramatically, I should say early in the year, but really throughout the year. There are a few quality measures for which performance improved, but overall, we saw declines in performance nationwide on quality measures. I also want to note that some plans did not report performance for all of the selected measures. So for those that did report the measures that we selected, we looked at what was their reported enrollment in 2020, and we used that as a weight to calculate a state level performance. Questions about that methodology? Okay, for commercial performance, we followed the same approach. We did a 2020 enrollment weighted average for Health Plan of Nevada, which is operated by United Healthcare and by Aetna. And for different products, for HMO point of service for Health Plan of Nevada and for PPO, EPO for Aetna. And we compared this performance to national commercial all lines of business. So all lines of business is inclusive of these different product type that you see here as acronyms. And then we compared performance to these benchmarks that you see laid out in the key on the bottom. So this is how NCQA reports benchmarks. They use these quartile measures with a highest performance being above the 90th percentile. So as I show you measures and performance on the next tables, know that if you're seeing pink, you're looking at below 25th or below 50th, and green is above 90th. All right, so here is initial data. We've got separate columns for commercial and Medicaid. We're displaying the actual rates, so this is a weighted average, and the color coding tells you how the state performed. So you see a lot of pink here. Basically, except for chlamydia screening, Nevada performance was either below the 25th percentile, which is deep pink, or between the 25th and 50th percentile, which is light pink. The exception here is chlamydia screening, where performance was, depending upon whether it was commercial or Medicaid, either between 50th and 75th or 75th and 90th. And you'll see there's a footnote indicating that there are some measures for which we did not have all three payers reporting for Medicaid. And so that's indicated. You will note in general that the commercial rates are often, but not always, higher than the Medicaid rates. And that's not unusual that we see that. There are some performance rates for which Medicaid is a little higher, at least in absolute terms. I'm not sure if it would be statistically significant in all cases. And you'll also see for colorectal cancer screening, there's no Medicaid rate because in 2020, colorectal cancer screening was not considered to be in the Medicaid measure set. So that's why there's no rate. Any questions about the information on the slide?
Michael, I do see one from Commissioner Tyler Garner.
Morning, just one question. In the cases where we did not have data for certain payers, do you have a sense of if the potential impact for these rankings? We're in the lower quartile on most things here, with the exception of chlamydia screenings, but I'm wondering in the case of the Medicaid performance, how much weight should we put in the rankings?
So in terms of the omitted language, the omitted rates, we really have no idea what those rates would have looked like since they weren't reported. And I don't know why they weren't reported. My recommendation is that you step back and look at this and see overall, there's a lot of pink. And so overall, there's significant opportunity for quality improvement in the state. And that opportunity is present for people with commercial coverage, and it's present for people with Medicaid coverage. Okay, I wouldn't focus too much on the individual rates or even the fact that there are a few Medicaid rates for which we're missing some health plans. My guess is that if we had data for the missing health plans, that the performance would not jump up to above the 90th percentile. Right, so, and you can see here, this is, on this slide, we've got a mix of measures. A lot of them are well care focused, a lot of cancer screening, but asthma medication ratio, blood pressure control, those measures are about management of chronic conditions, right? So this is just the first batch of measures. I've got another batch here. Controlling high blood pressure is a chronic condition management, and it's an outcome measure. Chronic condition management is eye exam for patients with diabetes. We've got 3 follow-up after ED visits or hospitalization for mental illness. So that's obviously a chronic illness measure. A1C poor control, that's chronic illness outcome measure. And then 1 well care measure, immunizations for adolescents. So here, performance is a little bit better. That deep orange means it's between the 50th and 75th percentile. So, certainly still with opportunity for improvement, but not as poor comparably as the pink colors. And you can see here, there's also, again, not significant differences in performance between commercial and Medicaid. While there's some variation from measure to measure, there's sort of an equal mix of color coding here when we're looking at performance relative to benchmark.
Commissioner Tyler Garner, did you have additional question? Okay, excellent. Please go ahead.
Just an additional clarifying question. These rankings are in comparison to others. So if nationally we're not doing well, like for example with mental health, then our ranking, because it's a comparison to others, it just essentially suggests, hey, we're doing about as poorly or about as well as others are doing. But it could be the case that nationally it's poor, that we should have higher expectations for the quality. Is that the
Absolutely,
case?
right. Yeah, sometimes I review data like this with states and they'll see that they're in the green, but let's say it's immunizations for adolescents and their rate is, I'm making this up, 60%. So you're still saying that 40% of all kids aren't getting required immunizations. So in that case, I sometimes will tell states, so you're the best student in a class of poor students. So while you look better relatively in absolute terms, you shouldn't feel, that you shouldn't feel really good that 40% of kids aren't getting immunized. Yeah. So this is just a relative comparison. This is just how Nevada compares to health insurers in other states across the country. This is the last batch of measures. Again, more pink than any other color, but a little orange. That deep orange again is 50th to 75th percentile. You'll note for all of these measures, there are only a couple of incidences where performance is above the 75th percentile and none where it's above the 90th. Okay, and again, I don't think we can say, as a state, we're doing better for people with commercial insurance or for people with Medicaid relative to benchmarks. Babette?
Is there a data set that's got the national averages that we could bump up against this? Not that you'd have to bring it back to us, but at least you could distribute it so that we could see how we're compared to the rest of the country.
Well, this is comparing you to the rest of the country. That's exactly what this is.
Okay.
Yeah. So the color scheme indicates
I see.
in which
Sorry.
quartile the state falls.
Okay,
So,
I thought it was just clear quartiles, not quartiles compared to the rest of the country.
no, it's all compared to the rest of the
25
country.
percentiles. Okay.
So every time you
Thank
see dark pink or light pink, that's below the 50th percentile.
Okay. Thank you.
Yep. Yeah, I apologize if I didn't explain that.
No, you probably did. I just missed it. Thank you.
So these are the health plan level measures. I think that they, while it's only looking at people enrolled in these health plans, and there are people covered by plans, especially in the commercial market, not captured here. I think this is a pretty good indication of quality of care compared to other parts of the country. Now, the next data I'm going to share with you has to do with hospitals. And again, this comes from the Medicare website. Oh, I'm sorry. First, I've got a summary. So overall, for 14% of the quality performance measures, the health plans were between the 75th and 90th percentile. For 59% below the 50th. So, again, there's clearly room for improvement. Right, so here's the hospital data. So the way that CMS reports its star ratings is on a scale of 1 to 5. And so you can see here that if 3 is the middle, that for this, and I have 2 tables of hospitals. For the hospitals overall, again, a lot of pink. And so, again, there's opportunity for improvement. And we selected hospitals simply based on size. And here's some more data. Okay, and the star ratings reflect a comparative analysis by CMS of where the hospitals stand in their performance on the CMS hospital quality measures. Babette? No? Okay. Tiffany?
Just a quick clarifying question. The patient survey ratings are their perception of the quality of care they receive, correct?
Right.
What comprises the overall star ratings? Are there some, and I'm sorry if you covered this.
No, I didn't explain it to you. So CMS has, actually, Mason probably knows it well because he lives by the star ratings. Mason, do you want to explain it?
Yes, I was appreciate the question because this is great data on comparing, but when you look at, so it's quality, hospital acquired conditions, outcomes. One of the things that they've combined, and we can all do a lot better in the state of Nevada, is on our patient surveys that go into that overall ranking called the Hcap scores. And we compare at UMC, and many of us compare each other to other like hospitals, but nationally and the state level. And while everybody's raising the bar, we're just not moving fast enough to keep up with the national level. But it's quality, it's outcomes, it's safety, it's mortality, hospital acquired conditions, because obviously we want to make sure that patients don't have any harm that comes in the facility. But then big impact is the Hcap scores, which is the patient survey mechanism that's across the board standardized nationally. So that unfortunately in the state of Nevada, we don't really do that well on the patient satisfaction, which brings down overall star rating for the hospitals. And Michael, what's the time frame on this? How far did this go through? And usually the federal government's a little bit behind on the data collection, but when did this data end? Do you have that?
So this is for 2020.
Okay, gotcha. Thank you.
Mm-hmm. Okay, so just summary. For the 12 largest hospitals, range from 1 to 3. No hospital scored higher than 3 stars for these summary level ratings. So this is the distribution for both the overall ratings and for the survey ratings.
So there's a quick question on Khan. Also keep in mind, for it to be apples to apples, the larger hospitals versus smaller hospitals, it is relatively easier for smaller hospitals to keep tabs on everything. The bigger the hospital gets, the more involved the process to keep tabs of all aspects of these benchmarks. So one needs to keep in mind, some of these are also very subjective benchmarks. Patient satisfaction involves multiple areas. Unhappy with the physician reflects on the hospital. Unhappy with the nurse reflects on the hospital.
Mason?
Yeah, and certainly not making any excuses, because the information is the information, and we could always do better in these scores. And as Dr. Khan, sometimes this is not acuity based, but just a reminder for the PPC is we had a lot of things working against us in 2020 with lack of visitors, canceling procedures. Many hospitals were in surge areas that weren't ideal for patient care. But again, not making any excuses, and that was nationally, but certainly our state was hit hard, especially with bed compression. So, but we have to do better in this, and the state keeps us honest on a lot of things as well, on some of their ratings. But we need to move the needle on improving our hospital ratings overall, and we acknowledge that. So.
Thanks, Mason. Tiffany?
Thank you. I'm wondering if there's an opportunity to see what the scores were the previous period then. So if we believe that part of it is strongly informed by the pandemic, were we somehow on track or having higher ratings prior to the pandemic?
Commissioner Tiffany, if I could, again, no excuse for these scores. And I wear another hat as the chairman of the NHA, and we know we can all do better in the state of Nevada. Hcaps is a big factor when they layered that in. And just so you know, the Hcap survey is not an easy survey to navigate. It's not an ideal, and you have different mechanisms. Some hospitals do it over the phone, some do it by mail, and it's a very cumbersome survey. Believe it or not, a lot of the hospitals now are really trying to go off of Yelp ratings, Google ratings, getting that real-time feedback. But it is the mechanism that is creates value-based purchasing and reimbursement incentive dollars for hospital. But I could tell you we could look back, but they're still well below the national average, and something that we all need to be doing better on in the provider community. So,
Babette?
Oh, thank you. Commissioner Matt Howling, I'm so glad you're on this commission, because I think you could, with your Nevada Hospital Association hat, maybe bring back to the commission things that you think would be helpful to improve these scores. You probably have ideas and strategies, and it would be really helpful. And I think, Michael, my question to you is there a way to compare the hospital systems to each other, like their sister hospitals in other states, to see if like UHH or HCA or Dignity, those are the three big systems we have that are national systems, how they do it elsewhere?
Yeah, that's possible.
That might be really helpful.
Mm-hmm. Yeah, that's possible.
And I certainly commit under the NHA, and I know Pat's listening too, is we'll put this on, we do talk about it, but we'll put this on an agenda to see what some of the common themes are, and continue to share best practices by facility. And congratulations to St. Mary's on their 3-star. That is not easy to achieve, and we recognize that, but we'll certainly have them share some of their best practices and ideas with the rest of the organization. And we're glad there's visibility on this, because there needs to be.
All right, so again, takeaway, big picture, there's room for improvement, obviously in hospital quality, as we saw with broader measures of primarily ambulatory care. Okay, so one of you also asked during the last meeting about what states were doing in terms of quality benchmarks. And so the next part of my presentation is going to convey that information to you. And then I'm going to ask you to reflect on whether there are any ideas that you want to begin to consider for improving quality. So of the 8 cost growth benchmark states, there are 2 that created parallel quality benchmarks, Delaware beginning in 2019 and Connecticut effective this year. Their measures are measures of both healthcare quality and of population health status in areas that in the 2 states they deem to be of highest priority. I will tell you that when we worked with Delaware, their governor became personally involved in selecting the measures for their benchmarks, which was quite extraordinary. For each of the measures used for the quality benchmarks, the state has created multi-year performance targets similar to what was done with the cost growth benchmark. So I'm going to give you a little profile of each of the states. First, Delaware started with 8 quality benchmark measures for their first 3 years. They subsequently discontinued 6 of them and really redefined their measure set. They now have 12 quality benchmarks for a 3-year time period of 2022 to 2024. They retained 6 from their original set, and these are the 6. So to the point I made earlier, some of these are assessing healthcare quality, and some of them are about population health status. Adult obesity is really a population health status measure. It's not about the performance of the healthcare delivery system. Whereas beta blocker treatment after heart attack and statin therapy for people with cardiovascular disease, these are both measures of healthcare system performance. So these are 6 measures that they retained, but I said they've got 12. So here are some others that they introduced effective in 2022. You can see they introduced a new focus, obviously, on preventive services with 3 cancer screening measures and a preventive dental services measure.
These are all population healthcare benchmarks, with the exception of those 2 that you highlighted.
So yes,
Screening, colorectal screening, cervical cancer, dental services. These are population health management.
Right, and the way that they perform the measurement is, for the most part, I think the obesity measure is different, but for the most part, they are collecting and aggregating data from their health insurers and doing so separately for Medicaid and commercial markets.
All right.
Babette, you have a question? All right, maybe she stepped away for a minute. Tiffany?
Thank you. Do you have a sense of what the drivers were or criteria for selecting or continuing or discontinuing? Like, was it informed by their ability to collect the data? Was it informed by the areas where there was the greatest opportunity or already some progress? Like, any sense of like how they selected and when they discontinued, why, and what they retained and why?
Yeah, so for Delaware, I was involved in their initial development of their benchmarks, but not in their recent revision. But I would say that initially it was based on a consideration of data like that which I shared in the tables for you earlier, where they looked at where were their greatest opportunities for improvement, and they also judged for which measures did they think, for which measures would there be the greatest impact on healthcare outcomes in the state. So which had opportunity for improvement and which were most impactful. They did, though, start with measures for which they had available data in some fashion. Babette, did you want to ask a question?
Oh, thank you. I lost power, so I had to come back. I think I'm just thinking along the lines that Commissioner Tyler Garner is. There's just got to be ways for us to, as a Patient Protection Commission, add some, oomph and some momentum on this. I appreciate Commissioner Van Holling's position in that he's worked hard with his hospital to provide good quality, and UMC has good quality. So I realize in some ways that the measures don't always totally support what's happening, But on the other hand, we clearly have so much work to do in these hospitals, and it would be really great to identify an initiative that the hospitals could support that could be a community initiative to work together on.
Mhm. I will note that the measures that I'm sharing with you from Delaware, none of them are hospital-based. Okay, that's not disagreeing with what you just said. I just want to.
Yes, that's why I'm speaking up. I see that.
Yeah, these are all, community ambulatory services. A lot of them, but not all of them, really are generated through the primary care practice. So Delaware, as I said, they set multiple year benchmarks. What they did was they established a 5-year aspirational performance goal initially, and then stepped back and said, okay, so what are incremental targets for us to get to our 5-year aspirational goal? They set separate benchmark values for commercial and Medicaid markets. And for their health status measures, they set just a statewide benchmark value. They are measuring performance at the state, market, insurer, and provider entity level, just like what you are doing with your benchmarks. But to date, they've only reported at the state and market levels. They've not reported at the insurer or provider entity level. So Connecticut doing something similar, and they just began this. They are phasing in implementation of 7 measures, so far fewer than Delaware. For 2022, they are implementing 3 measures. 2 of them are outcome measures, controlling high blood pressure and blood sugar control. Those 2 measures are often considered to be the highest priority ambulatory care quality measures because having uncontrolled high blood pressure puts someone at super high risk, as does poor A1C control. And their 3rd measure is a process measure related to management of another chronic condition, asthma. For phase 2, they are going to introduce a pediatric well care visit, 2 behavioral health measures, and an obesity equity measure. They found that there was a great disparity in obesity between the Black and white populations in the state. And so their benchmark is to reduce the inequity between the 2 populations in terms of frequency of obesity. They also have set separate market benchmark values. They did it for commercial Medicaid and Medicare Advantage. So Delaware didn't do Medicare Advantage. They also set a statewide benchmark value for their obesity equity measure. They will report their quality benchmark data publicly in concert with their reporting of their cost growth benchmark data. Tiffany.
I'm just wondering, as you consider our role as a commission, some of the proposed BDRs, are there connections that you're seeing between that and the types of measures that folks put into place? Should there be some connection between those things?
I don't see a connection, but I don't know that there needs to be a connection. In fact, I think that there are some things that you could do as a commission that don't require legislation. And in fact, what I'm about to share with you from Connecticut might be helpful in terms of you thinking about it. Okay. Yeah, I don't think that all initiatives to improve healthcare system performance require legislation. I'm not saying that some don't, but not all. All right, so Connecticut, unlike Delaware, they set these quality benchmarks through a committee that they created called their quality council. So it's an advisory body with stakeholders, but focused on quality. And they and the state agreed that simply setting a quality benchmark and then not doing anything to try to improve quality in those defined areas was unlikely to have any impact. And so the Quality Council has been discussing a range of strategies to help improve performance on their quality benchmarks. So I'm going to share with you what those are. They have only just recently recommended them. So first, Connecticut has a Connecticut aligned measure set. So this is a set of measures that have been developed through the Quality Council for use by insurers in value-based contracts with large provider organizations. And the idea is that the insurers, the payers, including, by the way, Medicaid, so both commercial payers and Medicaid, would adopt a common set of quality measures for contracting purposes so that they would strengthen the signal that they were sending through their contracts to providers about where to focus quality improvement effort. Because otherwise, each payer picks their own measures, and the provider contracting with multiple insurers says, well, so what am I supposed to do? They're giving me a financial incentive for this measure, but they're giving me a financial incentive for this measure. So Connecticut and a few other states address this by creating an aligned measure set. In order to propel performance on their benchmarks, they decided to include a core set of measures and include the quality benchmarks. So the aligned measure set heretofore had been existing as a menu. So there were, imagine a list of 15, 20 measures, and the insurers were expected to limit their contractual measures to only those on the list of 15 or 20. The core measure set is a set of measures that are expected to be used in every single contract by every payer. And so they put their quality benchmark measures, remember they're starting with 3, blood pressure control, blood sugar control, and asthma medication management, that they put those in their core set, asking that insurers always use those in every single contract. So that's a way of amplifying the prioritization and the financial incentive behind the measure. So that's underway for implementation in 2023. 2, the Office of the State Comptroller, think PEB, will adopt the quality benchmarks in its public employee health plan contracts effective in 2023. So they are aligning with their state purchasing activity. And as in most states, the public employee health plan is a very large and usually the largest purchaser in many states. So that's the second step that they took. 3, they're going to publicly report on the quality benchmarks beginning next spring at the same time that they report on the cost split benchmarks. And they're going to name names. So they will say, Acme Health System had a performance against the benchmark so that they either met it or they didn't meet it. And here's how they did on the quality benchmark measures as well. So cost performance and quality performance will be reported at the same time. And in addition, they're leveraging a state website that already existed, Health Scores CT, and they're going to put the quality benchmark information on that website in the future. So those are the first 3 steps, but they've got a few more. They intend to create some type of public recognition program of both provider organizations and payers that perform well or demonstrate improvement on the quality benchmarks. So they might not have met the benchmark, but their performance might have improved a lot over time. So either by achieving the benchmark or demonstrating improvement, there'll be some form of a public recognition program. They are going to partner with other state agencies on a public relations and education campaign around the quality benchmarks. And they're going to create a toolkit for provider organizations for how to improve quality in the areas targeted by the 3 quality benchmarks. So to help promote quality improvement activity within their state. Okay, so that's what, actually, before I go on here, that's what Connecticut is doing. It's a little bit more than Delaware. And I want to ask if you have any additional questions about those 2 states. No, okay. So my next question for you, Babette, go ahead.
I'll make it quick. Are there any states, Michael, that are focusing on a quality strategy that includes hospitals? Or any states where the hospitals have worked with the community on initiatives that you're aware of?
Yes, yeah. That wasn't our focus here because we were focused on first what's performance look like in the state, and then what are states doing on quality benchmarks, because that was the question. But are there quality improvement initiatives in other states that involve hospitals? Yes. I can't summarize them for you today.
Okay, but that's something we could have brought back to the commission.
Mm-hmm.
Okay.
Yeah. So the broad question I was going to throw out just for initial consideration today is, do you have interest in pursuing either a quality benchmark strategy or any other strategy that might help improve quality performance? And it's really just an open question. We don't have a series of options prepared for you today, but because you had asked about quality back at the March meeting and asked to see some data, that seemed to be an appropriate follow-up question for you. Tiffany?
I was just going to note that I would be supportive of us pursuing some quality benchmark strategies, and as a part of that process, contextualizing what is happening here in Nevada and prioritizing responding to the specific challenges that we're seeing.
Okay. Anybody else have any thoughts? Barbara?
Yeah, hi. So I know this sounds very strange, but as we're looking at a quality benchmark strategy, I think one thing we have to consider is that there are people who tend not to follow their doctor's advice all the time. I just want to make sure that they don't get pushed out of a service or pushed away from a doctor should they not be hitting the benchmark strategy that the doctor wants. And I've seen this happen in other states. That's why it makes me a little nervous. So.
Right. Yeah. Well, I would say with any strategy, you always want to anticipate undesired consequences that could result from the strategy. So I think your advice is well-based. Babette?
Thank you. I think I know I'm harping here, on the hospital pieces, which I know you didn't have ready today. And I think with Mason's support, or Mason, I hate to put you on the spot, Commissioner Van Helling, but are you okay taking the lead on bringing back to the PPC ideas that the Nevada Hospital Association could support on a community quality strategy, instead of having it imposed upon the hospitals without their ability to support it? Do you have ideas about that?
No, I think we would absolutely love to kind of have this discussion and embrace it. We have our annual meeting coming up very soon, and we often meet frequently. So I always provide an update to the Hospital Association on the activity of the PPC, and be glad to let them know that this is one that I agree. Let's come up with something together versus being told or imposed. So I think it'd be good to have that conversation, and be glad to do that. Any offline suggestions, let me know, but we'll certainly take it back to Pat and the membership. Thank you. I would also say to be also often we don't we'll actually bring back some of the initiatives that we're working on by hospital or by association too. There's a lot of things that are in the works that are being currently worked on that I think would be helpful to the PPC, seeing some of the data. But there's a lot of things that have been worked on that are constantly being reviewed, and the needle's moving on some of these too. So we'd be glad to bring back some of that as well.
Babette?
And then just in general, I want to support, I feel the same way that Commissioner Tyler Garner does. I think that quality is an important part of what the commission should be focused on. So if there are specific steps that we can take, and we could either bring our own, or I think it's very helpful, Michael, when you can comb the states and figure out some of the key things that are being done elsewhere, since we're just right now at like ground zero in the commission for priority setting on this. It'd be great to see what is available in each of the arena. I would say the ER and the hospitals, if Commissioner Van Helling's going to take that on, it'd be really helpful. And then I don't know how to categorize the other components, but I think that we should have a set that addresses, what's happening here.
Yeah, Tiffany asked much earlier about how states picked their areas of focus, and certainly having some process to identify priorities, which really means also having some criteria to identify priorities, is important because the opportunities are vast. Okay, I think looks like we've wrapped up the conversation for today, and I think we're out of time anyhow. Chair Khan?
We may have lost Chair Khan.
There
he is.
Hello, sorry, I was on mute. So we are at the end of this part?
We are.
Okay, so any public comments over there?
Let me just check. If you would like to give public comment, again, please press *9 to raise your hand. I am not seeing any public comment, Chair.
If none, then we have to wrap up, and we would like to adjourn unless somebody has some compelling reason not to. If not, then we stand adjourned. Thank you very much, everybody, for keeping pace with time.
Thank you.
Thank you.
Thank you.